Welcome to the Spinal Truth Show, weekly podcast edition. I'm your host, Dr. Caleb Slater, here with Chris. This week's topic is frozen shoulders.
It's actually really cold in here, and so I think I have one.
Perfect. That's how you get it.
That's what I assume. That's how you get it. Yeah.
Exposure to cold. So do you know what a frozen shoulder is, Chris?
I mean, I assume it has nothing to do with temperature, but probably
Has nothing to do with temperature.
The idea of it being immobile, stuck in position
Pretty
in some
much.
way.
So you have a capsule that surrounds your shoulder, and you picture it like, and around all joints, but picture it like saran wrap.
Okay.
And that saran wrap can kind of become like thick, fibrotic, less stretchy, okay, less pliable. And when that happens, you basically lose motion in all ranges, you get pain, and that's what frozen shoulder is.
So you not only lose mobility, but you get pain. Do you get pain at all times or only when you're trying to move?
It's pretty much when you're moving, but a lot of people have like pretty constant pain. I mean, like, and when we say moving, it's not like you're stretching all the way to end ranges, like you're just, it depends on the stage of it and the extent of it. But you know, if you're just reaching to get your coffee or putting your shoes on, like any type of movement, you have pain with.
I have shoulder pain. I'm not even kidding. I woke up with bad shoulder pain this morning because I was laying like this really long last night when I was sleeping. And I'm assuming this isn't frozen shoulder, but I do have a lot of shoulder pain right now.
Is it just pain on like the top right there?
Kind of more in between the blades.
Oh,
So that's different.
yeah.
But if I didn't get frozen shoulder from this, how do you get frozen shoulder then?
Well, all right. So if you, I'm kind of excited about this because we just did a podcast about ankle sprains, and I had to say, which I agree with, that ankle sprains are pretty much not a spine issue, not a nerve issue, right?
Yep.
The whole point of a lot of this show is that we've seen the spine cause a lot of symptoms that are getting mislabeled and misdiagnosed in the medical system.
That's right.
If you ask me, a spine issue and nerve issue is what causes frozen shoulder. And I have, I think, a better argument than the typical medical approach of, I don't know why.
So if I go to the doctor, they could diagnose me with frozen shoulder, but not tell me how I got frozen shoulder?
100%. So there's higher likelihoods of getting a frozen shoulder, and it tends to be women.
Okay.
I think it's like a 2-to-1 ratio, women to men, but don't quote me on that.
Interesting.
At a specific age, somewhere between like 45 and 55, and then there's also like the menopausal component for that. Some type of trauma, and this could be low-grade trauma, like a lot of times it's your dog pulled you on the leash too hard or you fell or something like that, and diabetics.
Interesting.
So there's like a cluster of, of people that are more likely to get it, but they have no idea on why people get it, what causes it.
Is there anything common between all those different groups of people, like groups of symptoms?
Well, so it's a good question. One thing that could be common, so you talk about like diabetics, menopausal, maybe even like age-related.
Is that like hormonal?
Hormonal, but like autonomic nervous system.
Okay.
So, and all right, so one of the telltale signs of, or the best way to, let's say, truly diagnose a frozen shoulder is to see if there's capsular changes, right? So like if that capsule has become thick and fibrotic, right? But that is just a symptom. That doesn't explain why did the capsule thicken in the first place. And again, there's predisposing factors, age, gender, diabetes, stuff like that, but that still doesn't explain the mechanism.
Right.
The mechanism, though, can be easily explained by a nerve issue. All right, C3 to C5 pretty much innervates the shoulder. Okay, so the shoulder, the muscles, the capsule, stuff like that. A problem in that area leading to changes in that nerve signal getting to those muscles, getting to that area, decreases the muscle contraction.
Okay.
That leads to decreased blood flow. That leads to increased metabolic waste in the tissue. Fluid exchange isn't happening, so like the tissue isn't getting its nutrient as well, and that can lead to fibrotic changes. Additionally, I think a lot of these problems are actually coming from the, like a couple areas together, but the upper thoracic spine. The upper thoracic spine has a large control in the sympathetic nervous system, so the autonomic nervous system. A problem in this area leads to low-grade inflammation, leads to blood flow changes. And like these are subtle, low-grade, not really perceptible too well on our current tests and imaging and stuff like that.
Yeah.
This leads to the same thing due to decreased circulation, could lead to fibrotic changes in the tissue. That to me, is a pretty logical way to explain this phenomenon, these findings.
If you'd like an appointment, go to thespinaltruth.com and schedule today. We offer both in-person and telehealth appointments, and unlike the medical system, we look to the root of your problem. We look to find the cause, the why your problem, your symptoms are there in the first place, and we expect quick improvement. We expect improvement in pain, range of motion, or strength in the first visit, and 50% or more improvement in most conditions within 4 to 5 sessions. So if you're tired of being in pain, if you're tired of the medical system and its approach failing you, and you want something different, go to thespinaltruth.com and schedule today. Now let's get back to the show.
So to boil it down in layman's terms, the problem that presents the symptoms in your shoulder would also present symptoms of other things in your body.
Yeah, well, it would cause, so it's basically like you're seeing problems downstream.
Yeah.
Right? So like you have a shoulder pain, you have a shoulder problem, but it's because that's a downstream issue. Your labrum or your capsule tightening, thickening, that is a downstream problem. That is because of a problem further up.
A previous yeah, exactly. Yeah.
Right.
It's just, I know you're not a fan of this, but is there an imaging way to see that your frozen shoulder that you're talking about, the fibrotic?
Yeah, so you can see the fibrotic changes on like an MRI.
Okay, so.
But again, that only explains the symptom, not the cause. And then so people say, well, if it's a nerve issue, you can get a nerve conduction velocity EMG test, right? Mm-hmm. Again, kind of a misconception. Those nerve conduction tests really only detect nerve damage, not nerve changes.
Okay.
Right? So they're basically, it's subclinical changes that are happening on these. And to kind of illustrate the point, like if you had chronic lower back pain, right? You can have chronic lower back pain but have no findings on an MRI, no changes on an MRI, right? So it's the MRI, the CT scan, the X-ray, the problem is imperceptible to those tests. And this is very, very common. Very, very common that people have pain, but they don't really have any findings on the imaging. Or conversely, they have no pain, but if you did a study where you took them, they had findings. So like the two might not correlate. And again, for nerve conduction, they're really looking for nerve damage, not nerve dysfunction.
So what is the difference between then, if you have a pinched nerve in your neck, how is that not damage? How do you determine?
It's the level of it. So like a damage, it starts to destroy like the axons or the myelin sheath of the nerve.
That's irreparable.
No, if you take pressure off, the nerve will repair over time.
Okay.
The only irreparable nerve issue is like a laceration. It's like a cut.
Yeah.
But again, like these are, you can have pressure on the nerve, but it doesn't show up on imaging. Remember, imaging is taken in a position of comfort. You're lying down. Like the weight of gravity, of the weight of your head, the weight of your body isn't putting pressure on this. You're in a position of comfort. You're lying down at rest. You're not moving, twisting, bending.
Yeah.
And by the way, especially if it's a disc-related issue, discs are kind of mobile. They can kind of move around. You can have a disc bulge right now in the position you're in, and you could change positions, you could cough, sneeze, and that disc bulge could change directions or could resolve. It's not overly common, but it's definitely possible.
Yeah. So what is the steps that a normal diagnosis for frozen shoulder looks like?
All right, so, and this is going to illustrate my point pretty well too. So if you have shoulder pain, you go to the doctor does x-rays to rule out any like fracture or anything, which is stupid if there's no trauma, but that's what insurances dictate, right? Then they're going to do some kind of test, move your shoulder around. They want to see you be restrictive in all planes. So restricted into external rotation, internal rotation, abduction, flexion, stuff like that, right? Then they might just diagnose you with frozen shoulder right then and there. You know, and your primary will send you to an ortho, you know. They might do further imaging like an MRI to see if there's any tears, like a rotator cuff tears, and or to view the capsule. Then they diagnose you. Likely you're going to receive a cortisone injection, so some pain relief anti-inflammatories, and then you're going to get sent to PT. How long do you think it takes for a typical frozen shoulder to resolve?
If you go to a PT?
If you do all the treatment that you get it evaluated, you get a cortisone injection.
6 months.
Okay. Normal recovery is somewhere around 1 to 2 years.
Wow.
And that's with or without treatment intervention.
That's without doing anything. It just.
Right. Well, with or without.
Yeah.
So, and that kind of shows you too, like with treatment, you might be able to nudge that maybe 3-6 months sooner. But regardless, it's 1 to 3 years. 1 to 3 years for this thing to resolve. Regardless of treatment, it takes that amount of time. And about 50% of people are still left with lingering issues, tightness, pain, for years or life after that.
All right. Before we get into the typical treatment methods and then your treatment methods for something like this, let me ask you this. If you're out there and you don't know if you have frozen shoulder, you don't know, you've never been diagnosed with it, can you kind of explain what it feels like? Is there people out there that possibly have the symptoms of frozen shoulder, unaware of it, but maybe lingering shoulder pain?
And to back up my point a little bit, there are studies that are saying what I'm saying. Okay, so I'm not alone here. There's not a lot of studies, but there are studies that say that C5, C6 radiculopathy, so nerve root issue, can mimic or even cause frozen shoulder. But let's say just mimic, right? So you can have frozen shoulder and it can get misdiagnosed as a rotator cuff issue, a bone spur. Because all of the symptoms are a labral issue, right? Like a labral tear. All of these symptoms kind of mesh together.
Okay.
So it's really hard to determine which one is the actual cause because you can get an MRI and by the time you're 50, if you get an MRI in your shoulder, you're like 60% likely to have a tear in your shoulder labrum.
Gotcha.
You're probably about 80% likely to have some type of tear or fraying in one or multiple of your rotator cuff tendons. Okay? And this is without pain whatsoever. So now you have pain, now you get this image, whatever they find in the image, they're gonna try to correlate to your symptoms. And if it's more prominent of a rotator cuff tear, they're gonna say you have a rotator cuff tear issue. If it's more prominent of a labral tear, they're gonna say you have a labral tear issue.
Okay.
If those aren't there, they're probably gonna say you have a frozen shoulder.
So before we get into your treatment specifically, would you treat all those things basically the same way or are they different?
Are you saying me or?
You, yeah.
So my method is so you come to me with a shoulder issue. I'm going to evaluate your shoulder. I'm not going to ignore the shoulder. I'm going to see how you can move it, how it's painful, where you're stiff, what you can do. You're going to tell me, what you can do. Can you lie on your right shoulder? Can you tuck in your shirt into your pants? Stuff like that. Can you wipe yourself? All of this stuff I'm going to map out. I'm going to map out your movements. But before I do anything at your shoulder, I'm going to take a look at your neck and upper back, the areas that have innervations that have an effect to your shoulder. I'm going to see if there's a problem there. If I find a problem, stiffness or pain, I'm going to try to treat it, and then we're going to take a look at your shoulder again and see if any of your symptoms changed. Normally with that, I expect changes that session. I expect to see some improvement. At the very least, I expect to see some improvement within a few days of the patient treating that area of their spine.
If you're out there and you're in pain, if you're tired of the current medical system failing you over and over and over again, just giving you answers that numb you, pacify you to your symptoms, and are largely based on medication, injections, and surgery, and you want a different way, maybe even a better way, look for my book, The Spinal Truth, A New World of Medicine. In it, each chapter I talk about a different symptom, different condition, different body part, and how I view it a little bit differently than the current medical system and how my treatment has helped so many people out there when they've been let down with the typical approach. This is the way I think medicine should be. This is the change in healthcare I think we deserve. So thespinaltruth.com, you can look for my book on Amazon, Kindle, Apple, and on audio.
If it's working, if it's helping, we'll continue down that road. If it's not, then we can go to your shoulder and look. But I'm telling you, and this is kind of why I'm here, is that it's rare. It's rare that I have to only look at the joint. It's rare that addressing the spine doesn't have more of an effect for your pain, your strength, your range of motion than addressing the shoulder itself.
So assuming I have a spine issue, basically a rotator cuff and a frozen shoulder and stuff, all is going to be affected by the similar.
Well, no. So remember, it's a good question. Remember, a rotator cuff tear, a labral tear, is likely to be there regardless of pain.
Right.
So you're miscorrelating the cause of your pain. This happens a lot.
I was more going along the lines of, I'm already diagnosed with one of these things.
Right. So I don't really follow other people's diagnoses because they're often wrong. Gotcha. And that being said, you don't want somebody to give you a label and then whoever you go to with that label, they only treat you based off of that and they don't do any of their own thinking. Like that's what a second opinion is, right?
Yeah.
And so I'll have that in the back of my mind, but I also want to do my due diligence. And often, I mean, and like almost all the time, they had more of a nerve issue, a spine issue, than they had a rotator cuff, a labral tear, a frozen shoulder, a capsule issue.
I think from a patient standpoint, though, it's pretty common that, hey, I have something. This doctor gave me a label. At least now I know how I can present this to their medical.
No, and I get that. The problem is that becomes dangerous.
Yeah,
right?
Because now, it
becomes limiting. You have this label, and you don't know how wrong that label could be. And to be fair, a lot of the medical field doesn't either. A lot of the medical field is just getting this wrong, and there's a whole bunch of reasons why this is the case. An over-reliance on imaging, an over-reliance on medication for treatment, and by the way, a 5-minute evaluation.
Yeah.
When's the last time you spent an hour with your doctor? Ever?
No.
Have you ever spent an hour with a doctor?
No.
So, and like my sessions are all an hour. My sessions, especially at the beginning, I'm asking so many questions. I'm seeing all your movements. I'm pressing on a lot of your joints and your vertebrae if you're in person. Like, and then after treatment, right then and there, I'm evaluating the effects of it. Whereas most of the time you go to the doctor, they give you a pill, an injection, or they tell you to go to therapy. And then regardless of what they told you to do, they see you a month, 3 months later, right? So like they're not evaluating things that quickly.
Yeah. So the standard treatment for frozen shoulder does that include things like injections and
it includes a cortisone injection is probably one of the main treatments,
which is not treatment.
Which is not treatment. It's just management of your symptoms, masking of your symptoms.
You probably feel good for a little while, right? Because it takes away the pain.
Normally helps.
Yeah.
So then you're going to go to physical therapy, and they're going to try to make you move your arm, or they're going to move your arm for you. So they'll do like joint mobilizations. They'll have you do stretching. It doesn't really work, and it often irritates the patient.
Well, if you had gotten a cortisone injection, kind of numbed yourself to the pain, is it even smart to start doing those kind of movements then after that?
I prefer to not treat patients when they've immediately had injections for that reason, because the injection is going to wear off, and within a few days, a week, maybe a month, the injection is going to wear off, and now they're going to be in more pain when it wears off, and you don't know why. You don't know if it was because what you were doing with them.
Right.
That being said, like it's not like they're completely numb, so they'll still have sensation, but in this same aspect of it, they're doing things that might be aggravating, irritating to their symptom, and they're not realizing it. So again, once the medication wears off, either you as the PT have been moving their joint into a painful range, or their nerve into a painful range, or they're doing it on their own, and now it's more irritated and the medication wore off, and now they're the same or worse.
Gotcha. We were talking about ankle sprains before. Walking it off is an element to treatment of that, getting the blood flow in there. Is there specific movements you should be doing then?
Well, and for my mind, it's treating your spine.
Yours is at the neck.
Yeah.
So nothing at the shoulder.
Neck and upper back. I actually think the upper back drives, specifically for frozen shoulder, I think it drives it more.
Okay.
So I'll have patients in earlier in my career, and to be fair to all the PTs at home, all the clinicians, all the doctors, I treated frozen shoulders this typical approach for the majority of my career. I've been a physical therapist for 17 years. I got an orthopedic specialty. I got a certification in manual therapy. So I'm quite literally an expert at this. Mm-hmm. And the expert way I treated it was the same bullshit that everybody else does.
Right.
I would do it with a higher degree in the sense like I knew all the manipulations and mobilizations to all of the joints, and like I'd mobilize your AC joint and your corticoclavicular joint, and I'd mobilize your glenohumeral joint in different ranges and positions.
Not my glenohumeral joint.
And I knew all of like the research and stuff like that, right? But despite being an expert in this, my patients didn't really get any better than anybody else's with this approach, Maybe they felt a little bit better. Maybe I was better at explaining it, or their symptoms, and they felt a little bit more confident with me. But I didn't see significant results. When I changed to a spine-focused approach, I see results within session.
Very fast.
Yeah.
So we talked about all those different diagnoses. You're talking about diabetes and menopause and all these things. Is there something that you now who treat frozen shoulder a bit differently, that you see as a common other symptom that they may have beyond the shoulder pain? Well,
it's problems that occur from an upper back issue. Okay.
Which would be?
It's a lot of like posture related changes. So like we're like this all the time, right?
Yep. Bend over.
That puts pressure on that area. That area can cause a whole host of symptoms, but the common ones would be like headaches, brain fog, shoulder pain, pain into the hands, especially like both hands, and into the entire distribution of the hands. Could even be some like breathing issues, heart rate issues come from that area as well. Even a little bit of like generalized fatigue. So a lot of these patients with this problem, they'll get diagnosed with something like POTS or fibromyalgia or AMPS if they're younger, something like that, and it's coming from this area.
So I work a lot like that. I bend over a lot, working on a computer and stuff. These symptoms, though, when we discuss them, they aren't all the time, right?
No, and that is indicative of a spine issue, right? And so we've talked about this, like what are some things that mean a nerve issue, a spine issue, and not like a joint, capsule, tendon issue, right?
Yeah.
And if sometimes it's there, sometimes it's not. That's more like a joint, a capsule, a muscle, tendon. They're kind of more structural bound. Like if you move into their limits, and if you're using them, it hurts. If you're not using them, they don't really hurt. Your spine, the nerves are kind of like, when they're irritated, they're irritated. It doesn't matter what position you're in for the most part. Like obviously you can irritate them more by stretching them or pulling or putting pressure on them. But if they're irritated whether you're at rest or not. Gotcha. Also, like if you're putting pressure on them because of a disc issue, as you're moving into different positions, and the disc is putting pressure on or off the nerve, you feel better, you feel worse. You feel better, you feel worse.
Gotcha.
Another sign, by the way, is if you have symptoms on both sides, bilateral, right? That's a big one.
That's definitely a nerve issue then.
I forget the percentage, but I think it's somewhere around, Danielle, maybe you can look this up, 35-ish% of people that get a frozen shoulder end up getting a frozen shoulder on the other side.
Maybe they're just keeping their house too cold.
It's cold house. So bilateral, right?
Yeah.
And here's another sign that it's likely a nerve issue if you're getting it on both sides.
So we talked about the frozen shoulder, it being fibrotic.
40 to 50%.
40 to 50%.
Yeah, that's crazy.
I was going to say 50, but I didn't want to.
So say they treat their neck, right? And that is probably the underlying cause, right? But isn't their shoulder still fibrotic? Don't they still need to break up those blood bundles?
You might.
Yeah.
You absolutely might. However, so restoring blood flow, muscle contraction should do that naturally over time.
Gotcha.
But what you need to do first is you need to treat the underlying cause, not the symptom. If you're just treating the symptom, then it's just going to either come back or you're not going to get as much effect, right? I kind of use if I need to strengthen my muscle.
Yeah.
Okay? But my muscle has lower nerve innervation, so that nerve signal isn't as strong, isn't as quick, right?
Yeah.
I can still strengthen this muscle. I can still see some gains if I work really hard in the gym.
Yeah.
But if I work first to restore that nerve signal, what I do in the gym will have significantly more effect.
Okay. I guess my thought process in asking that question was, how does the patient see the result even if it is their neck, but they still have that, you know what I mean?
Because remember, so the fibrotic changes might not be the really limiting factor.
Gotcha, okay.
So they might have pain, but the pain is primarily because they have an irritated nerve.
Gotcha, okay.
So you, obviously to the patient, so I've used this analogy to patients a lot. So patients will come in and they'll say, I have arthritis, can you help me? I'll say, long story short, no. If you have arthritis, whether or not, whatever I do, whatever anybody does, unless it's a joint replacement, right?
Yeah.
you are going to walk out of here with arthritis. Now, whether or not you have symptoms.
Gotcha. Pain.
Right.
Yeah,
Pain, limited range of motion, decreased strength, right? And if I told you that you had arthritis, but you had no symptoms whatsoever, would you really care?
No, I don't care, yeah.
Kind of the same thing with your capsule of your shoulder. If I said, hey, your capsule's fibrotic, and if we fix everything, it's fibrotic temporarily.
Yeah.
But if your capsule's still fibrotic, but you have full range of motion, no pain,
what does it matter?
full strength, do you care?
No.
No.
Okay. Yeah. All right. That makes a lot more sense. I didn't know if you would still maintain the pain from being fibrotic.
Yeah. I don't think the pain comes from, the capsule changes.
Gotcha. Okay.
And that's kind of illustrated too, where like people will get frozen shoulder like post-surgical, but post-surgical, like they'll have had a rotator cuff repair or even just like general surgery, and they'll get a frozen shoulder afterwards. Like it's not like your capsule became fibrotic that quickly. You pissed off the nervous system.
Gotcha. Now, the nervous system stuff makes sense if it's innervative from those parts in your spine, yes. But what about menopause or diabetes? Those, from my understanding, are very different.
Autonomic changes in your body, and so diabetes, the effect of diabetes is on your nerves.
Gotcha.
That's why people get poor circulation, sensation, stuff like that down into their extremities, right? It's through their decreased nerve signal.
Gotcha.
Menopause is an autonomic change, and that's what I'm saying about your upper thoracic spine. It controls your autonomic nervous system. So if it's already irritated, and now you throw more at it with diabetes or menopause or an injury, it didn't take as much effort to cause a change because it was pre-lit up.
So this may be a very ignorant question to ask.
Probably. I can't even believe you're asking this.
Then is there something you could do if you do have diabetes or you are going through menopause with your spine, your thoracic spine, that could maybe help with some of the symptoms?
Yeah, I actually think so.
Okay.
Well, and in my book, so there's a chapter on, wow, I'm blanking. What do women get that we don't get monthly?
Menopause? Oh, menstruation?
Yeah, I just wanted you to say it. Okay.
Because you didn't know.
Right, I definitely blanked there. So there's a chapter on that because some women have severe pain with it, right? Yeah. Some women just have discomfort. Mm-hmm. Why? One of the reasons might be that like an area of their spine, specifically the TL junction, is pathological, problematic, and they're not getting that signal, their innervation to their internal organs as well, or it's set up to, it's already irritated. Mm-hmm. And then when you throw in more irritation, more disruption, then you have that much more of symptoms.
Gotcha.
Same thing here with the shoulder.
Okay. So I go to my doctor, they say I got frozen shoulder, what do I do? Do I go see Dr. Caleb Slater?
Yeah, so it's annoying. It's annoying.
Yeah,
I don't want to keep saying like you have to see me. I'm working on books and series and stuff like that, and I want to teach other clinicians this process. But yeah, if you're asking me point blank, and I'm giving you my honest answer, my first answer would be see somebody who's going to treat your spine properly. The problem is that there's pretty much nobody out there. And I agree with all that. If just you're out there for the free information, would it not hurt them to just do a foam roller exercise? The foam roller is probably the one I start with, right? Yeah. And it helps with motion. You still need muscle contraction, so you need more than just that. But
it's a good starting
point. If you go to our carpal tunnel series or our thoracic outlet series, there's a few of those approaches are similar to what I would do for frozen shoulder. So you can try some of those. The foam roller, like what you said, is probably a staple. Most of the time, the patients that I treat for frozen shoulder end up saying that and another exercise are the two that are most helpful.
And I think just in general, doing that foam roller is probably helpful for anyone in this current lifestyle.
And here you go, right? Like, so let's say you go to the doctor, they say you have frozen shoulder. What do? You know from this podcast or just by looking it up that with conventional treatment, it's a 1 to 3 year response. 1 to 3 year, and then you still are likely to have lingering pain, stiffness.
Okay, and that's so 1 to 3 years. Is that because they haven't actually resolved the problem and it's just progressed even worse?
No, it's kind of, they call it a self-limiting diagnosis. It goes through quote unquote stages, the freezing, the frozen, and the thawing. And it's basically like your body just adjusts over time.
You get used to the pain.
You get used to it, your body adjusts, you move through it. The nerve signal initially was really irritable, and then over time, either it dies to the point where it's not as irritable, or it's recovering.
Do the people who've gone through those 2 or 3 years of recovery, do they now, for eternity, accept limited mobility?
A lot of them, yeah.
Yeah, see, that's terrible, right?
Right. Or you could see me, and within 5 weeks, I expect 50% improvement.
That's right.
Like you have those two options, and I'm pricey. I'm not in your area. I do treat over telehealth, but if it works, not only does it work very quickly, but we've also treated the underlying cause.
And we've shown you how to, if the symptoms arise again, what to do about it.
And we've shown you also too, and what I think is kind of invaluable, we've shown you a different way to look at your body, a different way to understand your body, its symptoms, what it's telling you, right? To maybe not accept at face value what the current medical system is giving you, and maybe look a little bit further, maybe push back a little bit. And for most people, they should understand this at a pretty a pretty basic level, because the current medical system sucks.
Yeah.
Again, it's your 5-minute appointment that is strongly rooted in imaging and medication. And it's doing nothing to explain the underlying cause. You're not even looking for it. And the treatment specifically for this, it's ineffective. You know what another treatment is for frozen shoulder? Surgical manipulation. So manipulation under anesthesia. Do you know what that is?
They move things that...
So I can't, let's say for frozen shoulder, I can't move my arm above my shoulder.
They force it.
They put you under anesthesia and they force it. And it is aggressive.
And I'm guessing after that anesthesia wears off, you're pretty sore.
You are not happy for the most part, yeah. You know, every once in a while you get a patient that's like, oh man, that really helped. But for the most part, you're in pretty acute pain for a while. It's almost like somebody wrenched your shoulder beyond what it should go. So the medical community's answer to a frozen shoulder surgically is grip it and rip it.
Yeah, that's crazy. When you get your typical diagnosis, do they tell you that it's going to be like a year or two before you recover? It's
a good question. I don't know.
Okay.
They might. I think that'd be kind of dependent on the clinician.
Got you.
But I mean, you can look it up.
Yeah.
Just look it up. It's most common. It's 1 to 2 years, but a lot of people it's 3 or more.
If there are people out there listening who are diagnosed with frozen shoulder, I want to know, and I want to leave in the comments how long they've been dealing with frozen shoulder.
Yeah. No, that'd be great.
Just out of curiosity. When you're talking about shoulders and stuff like that, it makes it seem like this would be more of an athletic person problem, or someone who does something, with full motor or full motion in their shoulder.
But that's going to kind of support my argument.
That it's not,
because it's not,
it's
right?
Your grandma.
It's not like you're out rock climbing and you're like, oh, I got my frozen shoulder, right?
Exactly.
It's you're like, I've been sitting in my office. I wake up, I drive to the work, I sit at work, I drive home, I cook dinner, which is looking down, and then I sit and I watch Netflix.
And you're like, oh, my shoulder.
And you got and all of a sudden you got a torn labrum and a torn rotator cuff and a frozen shoulder, and you're like, no, you didn't do anything to, especially with the tears, right?
Yeah.
Most people didn't do anything for the tears, and they're getting diagnosed with these tears because they had pain and they got imaging, and you're like, well, why did I get tears in the first place? But it's not explained to them, and it's just, hey, here's your problem, here's your solution. And then by the way, a lot of shoulders, just talking about labral tears and rotator cuffs, a lot of shoulders are one of the more painful and lengthy recoveries.
Yeah.
And by the way, guess what explains why? It's because you had an underlying nerve issue, and now you're going through post-surgical recovery with your problem further irritated from the surgery.
My fear with stuff like this, it's always the same. It's that it sounds too simple, and the people who have been dealing with this have likely been dealing with it for a long time, and they don't want to accept the fact that it could just be.
And I get that. I mean? I really do get that. But go with what sounds logical. Go with what sounds more likely. Is it more likely a diagnosis that has no cause?
Yeah.
That takes 1 to 3 years to resolve regardless of treatment or intervention, and that intervention, by the way, is putting you under anesthesia and ripping your arm, right? Or mobilizing your arm in the clinic and causing you to leave and like it hurts more than when you came in and stuff like that, right?
Yeah.
And that you'll be left with lingering issues or it'll go to the other side.
Yeah.
Is that more likely, or is it more likely that you had a nerve irritation that can actually explain why those changes were there in the first place, why your treatment isn't effective?
Yeah. No, I agree.
I like what you said, you know, just for people that are listening, if you've had frozen shoulder, how long has it been? And you know what? You know what's a good one? If you had frozen shoulder, leave it in the comments if you had a neck or upper back issue in the past.
Yeah.
Or if you didn't, if you're like, hey, I've never had a neck problem, I've never had an upper back problem, and I got frozen shoulder, leave that in the comments. But I think that's going to be a lot less likely.
Yeah. Did you watch Game of Thrones?
Of course.
Do you think all those people in the north had frozen shoulder issues?
2 frozen shoulders.
That's right. So, frozen shoulders.
We did it.
We did it, and it doesn't seem like that complicated of a treatment.
Well, the current system it is.
Yeah.
Yeah, no, but I mean, and that's my point, right? Like, which one sounds more logical? Which one sounds more complicated?
Yeah.
Right? Is it this weird undiagnosable cause, or is you're like, hey, you got it wrong. You're looking in the wrong place.
Yeah. You let us know.
Yeah. All right, that's our show. Thank you for watching. Hopefully you learned something from this. If we didn't answer your questions, you can reach out to us at info@thespinaltruth.com. You can leave a comment on our TikTok, Instagram, YouTube, or Facebook.
Yep.
Follow us on Spotify and stay tuned next week for our show.